We'll start off with Dr. Charles Friedman. He's the chair of the Department of Learning Health Sciences at the University of Michigan. He's the Josiah Macy Jr. Professor of Medical Education. And for many of us, he's sort of one of the champions of the learning health system, which many of you have heard about. We're then going to go to Alan Flynn, who will basically talk to us about some work that's really gone on and something that is part of the platform infrastructure. Last year we talked about learning health for Michigan quite a bit, and it'll take us a little bit into sort of the meat. Then I'm going to talk a little bit about how the infrastructure we've built ties in to this sort of learning health platform. And then after that, Dr. Jodyn Platt is going to speak to us about sort of the trust and the trust fabric for how we tie all these pieces together. So with that, I'm going to turn it over to Dr. Friedman.
Big green button. Thank you, Tim. I've spoken about the learning health system at greater length than I will today at previous meetings of Connecting Health for Michigan, and I'm very pleased to be here again. I know that Dr. DeSalvo referred to the learning health system in her talks. I'm just going to take about 10 minutes and review very quickly to set up the presentations and the discussion that will follow, what the learning health system is, and some key features that will be referred to by the speakers that follow. I like the very concise definition of a learning health system that appears at the top of this slide, that a health system at any level of scale, and I'm going to return to this concept of scale a few times in my presentation, becomes a learning health system when it can continuously and routinely study and improve itself. Really, that is the nub of the idea. The idea is simple and appealing. Making that idea happen in practice is daunting and something that many of us are engaged in hoping to see very soon. The learning health system idea was actually originated by the Institute of Medicine. There have been many articles about it, including an article that I'll refer to here by Julia Adler-Milstein's dad, which gave a great deal of legitimacy to the concept, where he said that one of the three things that this nation must do to safely reduce the health GDP footprint is to adopt the learning health system. And finally, as Dr. DeSalvo said, that the ONC has taken great interest in this concept. I'm pleased to have been a part of at least the origination of that when I was at ONC, and realizing a learning health system now I think can be safely called a pillar goal of federal health IT policy. Very, very quickly, and maybe this checklist is probably the easiest way of understanding what a learning health system is. I would argue that a health system that can answer yes to every one of these points, which can be phrased as questions just as easily as statements, can call itself a learning health system. So framing them as questions: is every consenting patient's characteristics and experience available to learn from? Is the best practice knowledge that occurs from that learning, that results from that learning, immediately available to support decisions by patients, by providers, by administrators, by other stakeholders? Do we do this continuously through ongoing cycles of study and improvement? Or are we kind of bursty? We identify a problem, address it, and then go into some kind of dormant state. If we're a learning health system, we're doing this all the time. Is this supported by an essential infrastructure that enables this continuous study and improvement to happen routinely and with economy of scale? This is essential, and this point about infrastructure will be really a fundamental aspect of what both Tim and Alan will be speaking about, and the trust fabric essential to maintain and establish this infrastructure will be addressed by Jodyn. And finally, is all of this part of the culture? If you ask people in a health system, why do you do this? And they say, you know, this is who we are. This is a part of us. If that's the answer they give, then that would suggest that this health system is a learning health system. Learning happens using a concept that's probably very familiar to most of you. It's this idea of a virtuous cycle of study and improvement that puts data to work. The analysis generates results, which generate knowledge. The knowledge, most important to a learning health system, is then applied through some kind of messaging to decision makers who then take action, which changes the system, in most cases improving whatever is the problem of interest and laying the basis for the next cycle of study and interpretation and change, over which time whatever the problem is that is driving this particular learning cycle realizes improvement. Infrastructure. What makes the learning health system a system can be viewed as the presence not just of a number of learning cycles that are going on, addressing different problems, progressing at different speeds, but the presence of an infrastructure, which is shown here as that supporting ring underneath these multiple learning cycles, that supports all of them with common services. And this platform must be viewed as a socio-technical or cyber-social platform that includes people, technology, policy, and process. So the learning health system can't be seen as being something just about putting the right technology in place. That technology must be accompanied by a number of other features or aspects, including policy and process and the cultural issues that fold into the people who are participating in the system. Back to this concept of scale now. Learning health systems can exist at any level of scale. A single organization can be a learning health system. A network of organizations, of different organizations, can come together to form a learning system at that level of scale. What we're really about today is the idea that a state, a territory, or region can, at its level of scale, be a learning health system. The entire nation can be a learning nation, can be a learning health system at that level of scale, and there are even those audacious enough to believe that the entire planet someday may be a learning health system at its level of scale. I'm frequently asked, well, do any learning health systems exist? And at the lower levels of scale, at the organizational level, at the network level, the answer to this question is almost certainly yes. It's dangerous to name organizations because then people say, well, what about us? But I will point out 4 organizations that I would argue could check all 5 of those boxes on my checklist. These are organizations depicted on this slide: Geisinger, Mayo, Kaiser Permanente, and Intermountain Healthcare, that I would argue have become learning health systems at their level of scale. They apply this learning process, this process of study and change, learning cycles, as I described them earlier, to all of their patients and across all conditions. But the key point about these organizational level learning systems that exist, that each one has developed its own idiosyncratic way of doing this, and I don't mean idiosyncratic as a criticism, that some of these organizations started doing this 25 years ago. Each one has developed a platform, an infrastructure that supports its own learning activities, but those infrastructures look very different from one another and almost certainly could not transfer to another organization. At the network level of scale, one level up, we can point to a growth that is happening so quickly that it's almost impossible to keep track of. And these 5 examples, which I'm showing you here, are examples of networks that are conducting learning activities, usually focused on specific sets of diseases, but across organizations. And the important point here is that in order to operate across organizations, they have to develop infrastructures that work across all of those organizations. And these networks, the Healthcare Systems Research Network, our own Michigan Surgical Quality Collaborative, the new ASCO Cancer Link project, what is going on nationally, supported by PCORI and the PCORNet, and the FDA's Sentinel initiative, are all examples of different organizations coming together, sharing data, learning, improving care. That's important, but equally important from the point of view of realizing a learning health system for the nation, ultimately, is they're figuring out how to do it across organizations. They are putting in place infrastructure that is not uniquely fitted to one organization, encountering a whole number of challenges and solving them in doing this. This is very interesting, what is happening at the network level. So to the next level of scale, what about the state? Many of us, and I should acknowledge the work of CHART, the Center for Healthcare Research and Transformation, directed by Marianne Udow-Phillips, which has been, for the past 2 years, the lead organization in trying to take Michigan to this status of being a learning health state. We are making progress. If we're going to become a learning health system at the state level, take a look at these points, which would, based on that checklist I showed earlier, would be the things that we'd be doing on a state level. The data from across the entire state would be available for analysis. The resulting knowledge that is generated by analysis of this statewide data would be available statewide. Statewide communities would form to study problems of shared interest and initiate and conduct learning cycles, like I illustrated before, around those specific problems. But an infrastructure would be supporting all of those learning cycles, and it would be a statewide infrastructure. And lastly, but certainly not least, a trust fabric would exist among all stakeholders, so this would indeed, over time, become part of the culture of health in the state of Michigan. So this is my last slide, and to create a transition to the next speakers, I want to leave you personally with the thought that collectively we are getting there. We are moving toward, in Michigan, becoming a learning health state. We are doing this by constructing elements of a platform, elements of an infrastructure that would support this ongoing systematic learning at state scale, supporting, as you see in the upper right of the slide, multiple learning cycles that would address problems of interest, doing this statewide, with statewide data, generating statewide knowledge, applying that statewide. My colleagues will pick it up from here. Alan Flynn will speak immediately after me. We'll talk about how we might envision creating a statewide grid, a knowledge grid for sharing the information statewide that is generated in a Michigan-based learning health system. Tim will then address the data side of this, looking at what data resources exist through MiHIN and predominantly that can drive the essential data aspects of a learning health system. And then Jodyn Platt will conclude the presentations by looking at this all-important notion of a trust fabric, how we might get there, and how it will really be the initial step in developing a learning health culture for the state. Thank you very much. I'll turn it over to Alan.
Well, thank you, Chuck, for getting our panel off to such a great start today. And I want to thank all of the organizers also for this meeting and for the invitation as well. And I want to thank all of you for coming to this session. I'm Alan Flynn. I have the opportunity to work in the Department of Learning Health Sciences at the University of Michigan. And today I'll be talking about work that we're doing in the area of knowledge organization within communities of learning, really thinking about some of the issues of infrastructure that Dr. Friedman has just introduced. So a good place to pick up then is on this idea of a learning cycle. And let's break this down a little bit, take a little closer look at some parts and pieces here. So the way we sometimes think about starting learning work is by collecting data and then taking that data and assembling it. This could be putting data in a registry or otherwise collecting it, protecting it, making it available for analysis. Then, of course, there's an analytic process that we have here in this learning cycle loop. And we get to the top of the loop where we have this human process. Often we think of this in a learning community. This process would take place of people getting together to look at and interpret results, analytical results from data analysis for health. During this process, we imagine that several key questions need to be asked and answered, and I've put them up here in this bracket. So one, have we learned anything about the problem from our analysis? If we've learned something, if the community of learners who are looking at these data and who have performed or overseen this analysis, determining that something has been learned, what is it? What have we learned within the context of a community of learners focused on a particular health problem? And if we've learned something and we can say what it is that we've learned, that means we have some explicit knowledge. So then the question is, how are we going to represent that new knowledge that's been gained so that it can be applied in the world? So these are three pretty important questions that have to be addressed at this part of the learning cycle. And we'll take another look a little more closely at what can happen here. So really, to be truthful here, we have to point out that there is the possibility that nothing is learned. And so in that case, we can imagine starting over. So when would this happen? Well, this might happen when some data was collected and analyzed. It just was insufficient to answer the questions that the community was most interested in. So go back and get more data, or we couldn't quite figure out which way to go. It could also happen when we gather some data, and what the data does is it provides us with new hypotheses, more questions than answers. And so then we might go back and start over and gather new but different data in order to go after some questions that we didn't start with originally. In any case, it's important to point out that it's not always going to be the case that just by doing analytic work, we're going to learn something new. But let's be positive. We can and do learn from doing analytic work. And so if we do have new knowledge, which I'm representing here with a single letter K, just to be succinct, if we have this new knowledge that we've learned in the context of a learning health system, in the context of a learning community that is performing learning cycles, now what? What do we do with the new knowledge? And so this is where I've been spending a lot of my time and effort really thinking about how are we going to answer that question effectively? What should we do with this knowledge? And one of the things that we know is that we want to take the new knowledge that we have gained from doing the work on the left-hand side of the circle, and we want to somehow figure out how we can translate that, which often means localize that knowledge, disseminate it, implement it in practice to actually make change. So there are entire bodies of scientific work that point to and look at translation, dissemination, and implementation on this side of the learning cycle. So there's a lot of effort that needs to go into these processes for sure. What we're thinking about, what I'm thinking about, and the team I get to work with as infrastructuralists, we're really thinking about how can we support this type of work. So in this question of what new knowledge was learned, you may be wondering, well, what types of things are we pointing to and calling knowledge in this context? So we're really thinking about explicit knowledge, things that can be written down, and they may come in many forms. So things that we're familiar with, regression equations, predictive models, checklists, templates, guidelines, order sets, and so on. These types of things that are being managed across the healthcare system today, these types of things that show up on our knowledge bases, rules and otherwise, are the kind of things that we have in mind when we're talking about learning something new and then representing what that is. So one of the things that we're working on in the department, we have a project focused on answering this question: how can we store this new knowledge to support the practice, this knowledge to practice transition that happens on the right side of a learning cycle, the red side. And so we're really thinking about storing this explicit knowledge and representing it in one or more useful forms. And of course, knowledge bases are nothing new, but what we're thinking a lot about is how can we make a knowledge base that's effective enough to keep up with the rapid pace of change in order to support as infrastructure the kind of learning at scale that we really have in mind for a learning health system. And so that really pushes the concept of a knowledge base potentially in a new direction, and that's what we're going after. So I've put that on here just as a black box. So there is technology involved here, of course, and so we want to come up with a means to store the new knowledge that we're gathering from these learning cycles in a way that we can immediately, as Dr. Friedman pointed out, act on it and make use of it. And that's a real challenge. So when we think about this black box that has the knowledge in it, this explicit knowledge, and we want to represent that knowledge in a way that makes it computable or machine interpretable, and that's an important concept here in this type of a digital library. So the knowledge that I'm talking about gets represented in a way that it's computable. So not necessarily a PDF that we can grab from a library database today, but actual code that encodes those rules or encodes that knowledge. We want to put that into a digital library, and so this work is really in the area of knowledge organization. We're borrowing on a lot of important lessons learned from information science and from the library world in our work, and we're thinking about this, and I put this in giant quotes, as a kind of brain for the learning health system, a way of remembering what's been learned as we're going through one learning cycle after another. But not only remembering what's been learned, drawing on those memories of what's been learned in an immediate fashion. And so this is what we want to think about in terms of technology support for this side of the learning cycle in part. Now, if we were able to achieve that, and I do think it's within our grasp, if we were able to create the kind of digital library of computable health knowledge that we have in mind and that we're currently working on, one of the things that we're thinking about that will be absolutely necessary is to come up with a mechanism that allows us to connect multiple different libraries like this across a grid. So here you can imagine across the state of Michigan many different organizations who are doing continuous learning for health in the manner of a learning health system, having a library where they put their knowledge in a computable form and then connecting that library to others who are doing similar work in different domains so that we can create a grid of health knowledge, a grid of connected libraries. So this is the vision that we have for how this technology might fit to help support learning cycles. It's not the whole story of the infrastructure, of course, it's just one component, but we think it's a critical one. So I wanted to leave you with this slide, an example of what this statewide knowledge to practice infrastructure might allow us to do is to begin to share knowledge across various different organizations. I've put 3 here. I didn't name organizations, just giving you the concept that 3 organizations might exist in our state. One focused on infectious disease, one focused on medication access for consumers, and another one focused on health care and a health system. And imagine that these organizations are all facing the same very difficult and challenging problem about making sure that antibiotics are used appropriately across the state. Well, each organization, as they're conducting their learning cycles, is learning something different aspects about this same problem. And so what we're proposing and what we're working toward is a way to combine those different perspectives and different aspects and different types of knowledge across a grid and so that ultimately we can then support the vision that Dr. Friedman laid out of a learning health system across the entire state, where we could take knowledge from various sectors and various organizations, working hard to generate that across the state, share it statewide, and drive it into practice change and improvement for the whole state. Thank you.
So what I wanted to do is connect that sort of big picture vision to kind of where we are and maybe make this more concrete for some folks. Most of you in the room should be familiar with the sort of active care relationship infrastructure that we have that's, sort of 8.5, 9 million plus, and the sort of pervasive ADTs. There's a handful of organizations that I would say, raise your hand if you've been kind of learning, your organization's been learning how to digest ADTs just to sort of process them. Yes? A couple of you, raise them high. Come on, be brave. Yeah, okay. So I thought what I would, I thought what I'd do is this process of just something simple like getting access to these notifications and alerts that's sort of happening statewide, and MiHIN has showed this slide lots and lots of times, but all the ADTs are available and they're all able to be delivered to folks. And you heard from Dr. Kendrick, increasingly you should expect that that's going to be a nationwide infrastructure someday that you can build on, okay? Well, here's the learning piece that what's happening is when somebody receives the ADT, there's an analysis process that happens on the sort of data side of this curve, and people have had to learn something. They've actually had to learn a fairly actionable set of steps to figure out how are we going to take this digital knowledge object. And when Alan talked about the sort of vision in pieces, this is being built into a digital library that's based on an open source infrastructure that the library community has advanced in the sort of cyber infrastructure space for quite some time. So it's a real tangible infrastructure where that digital knowledge object can be stored that says, what's sort of our checklist or guideline or best practice or care coordination actionable event to build off of what do we do when we get that kind of alert? Well, then there's obviously a practice change, which is it's another piece of the learning health system, and there's good science behind that. But right now we're talking about managing these digital learning objects. Well, we complete the cycle, okay, and now we have ADTs and we've learned how to do that, but now we want to say, well, what happens if we're able to add in risk scores? Now, everybody's got their own crazy way for doing risk scores and that kind of stratification. What if you could begin to put those algorithms as a knowledge object and package it up with what you do there? And so basically the next time around, we've actually got learning that has occurred because we've now learned how to deal with ADTs, how to do that transition to care, but now we've got kind of a new set of things based on what happens when we have the risk score. There's another kind of learning object. Now, because this is going into a database instead of trapped in some sort of rule system in one of our EHRs or in some other proprietary database, but being abstracted out into something that you can organize and measure and count, suddenly you're beginning able to quantify and share knowledge. So we go around the cycle again. There's a different practice change that's associated with it. And now we say, boy, wouldn't it be great if we thought about our consumers and we wanted to do consumer engagement and we got a patient activation score this time. And so now we want to know, well, exactly how activated is this patient? What's the risk score and what's the transition of care? Suddenly we've now created yet another kind of learning. And all of these learnings are hard and painful because they all translate into practice change. But it begins to add a level of rigor and formalism and actually creating infrastructure to begin to track what we've learned. And this is just on ADTs. There's lots of big data algorithms and utilities that follow this pattern and can begin to go into the library. If this is something that interests you, the Connecting Health for Michigan folks had kind of a summit a while back. There'll be another summit in the fall where some of this work will be kind of rolled out so you can kind of see, well, what are the application bases and some of the tools look like, and how might we begin to share some of that learning collectively. Jody?
Thank you. I'm very excited to be here, and I get to sort of speak last this afternoon about this trust fabric that Chuck talked about that gets folded into a lot of conversations about the learning health system, about large health, about sort of big health data, and about our nation's health information infrastructure. It's sort of a word, but what I'd like to do in the next 10 minutes is to begin to describe what this word really means and what it's going to mean in our work in the state of Michigan. And to sort of begin the story of the trust fabric is to begin to tell the stories of sort of take a step away from the technology to the people that are being reflected by the data that you're collecting and the data that you're analyzing and reporting back, and to understand that even as we're building out longitudinal health record, that longitudinal health record is reflecting a life over time. And that to build trust is to figure out how to connect the people to the data and the data to the people at the right times and in the right places. And again, we're sort of building out the right kinds of tools to enable data sharing on a scale that we haven't seen before. We're developing business models, and somebody talked yesterday about how we're being very creative in our business models, but some of those are going to fail. And we're able to also sort of be agnostic to the ways in which data are originally collected and use it for all kinds of purposes. We can use it for quality improvement, we can use it for public health, we can use it for clinical care, and that's amazing, but that's not the way our policy infrastructure is currently constructed to sort of allow for this fluidity of data at the scale that we'd like to do it. We talk about a learning health system. There's no sort of a learning health policy paradigm out there right now. And we also are, again, it's sort of a scale issue. So we're able to do it on a small scale. We're also able to do it on a very large scale. There are 10 million people that live in Michigan. That's a lot of people. And so what we have is sort of a really interesting and exciting set of tools. And right now, sort of one of the major ways that we can contact people is through a one-time consent. And this one-time consent is going to remain important in whatever we do moving forward, but it's somewhat ill-suited for the time scales that we want to be able to build out an infrastructure that will last forever, if possible. And we can certainly build out security models that also are going to be able to sort of help support that infrastructure. But again, this is why we talk about trust, because trust is the thing that's going to be able to sort of fill in the gaps. So if we have a complex system and an imperfect system, but I can trust that you are going to basically do the right thing by my health information, if I can trust that you're competent in the things that you're doing, you're expert in your jobs, and if I can trust that you're going to be honest with me about when a mistake is made, or that you're going to let me know that you find something that I need to know about my health, if I can sort of trust that that's happening behind the scenes, I don't need to be involved. And you can do your amazing work, and I can live my life. I can get married and have children and go to work and get my kids to school and do the things that are hard, but I don't need to worry about where my health information is on any given day. So in order to sort of fill in that blank space where trust is, we need to be able, what we're going to sort of do for the rest of this time is figure out how can we make trust visible? How can we make it measurable? And then how can we sort of harness the power, I'll tell you the secret right now, the power of trust lies in dynamic connections. And that's where we're really going to sort of see our health information infrastructure be able to run with the power of the trust fabric sort of behind it and supporting it. So to make trust visible is to define it, and you'll generally see sort of definitions of trust. They sort of circle around the notion that it's the willingness, an optimistic willingness to be vulnerable to another person or another entity to perform a given set of tasks. So in the example that's on this slide, Chris trusts the health system to take good care of his data, but you can imagine any number of permutations of that. It can be a doctor trusts the payment system to pay for the services that he provides. And again, if you want to drill deeper into sort of what trust is, you can often sort of describe it in these three dimensions. It can be, it's generally sort of a reflection of competency, integrity, and fidelity. So whose best interests are being served? If I feel like my best interests are being served, even though you're doing the work, I'm okay with it. I'm not going to spend a lot of time on this slide in terms of what kinds of activities we're doing to sort of be able to measure trust in a variety of sort of clinical contexts, but also in the public domain where people may not be in the clinic. but they may not be patients, but they're the public who are going to support the investments in our national health, in our state health infrastructure. So trust me, we're doing work on that. Because this is sort of the fun part. This is where we can sort of see where trust can sort of connect people to ideas, people to structures, and people to other people to sort of make this a robust trust fabric that will support a learning healthcare system in Michigan, a learning health system in Michigan. So we'll sort of take each of these in turn. So let's start with the people and ideas notion. And in November, and I hope you all come to Ann Arbor, because we're going to sort of talk about what are these sort of new policy and ethical frameworks we need to be able to use health information in a learning health system and on a scale that can involve the entire state. So that'll be November 18th. We'll sort of bring together ethicists, policy people, community members, and begin to sort of grapple with the crazy ideas, because that's sort of where it all starts. So it may be sort of how do we develop a system that in which we're authenticating users of health information and not each of the one-off uses. How can we really open up the public health system so that people find that an accessible enterprise? The other thing that we'd like to be able to do is really be able to map the community power structures so that when we want to do outreach to the community, we know who to contact, and we can do it systematically, and we know where to put our resources in a way that makes our outreach to community a more sort of efficient endeavor. And this is the kind of thing that can help things like the state innovation model really, really run. If you know who the community is, who the community attractors are, and why an intervention that you may have designed for Genesee County isn't going to work as well in Washington and vice versa. There are historical reasons for that, there are political reasons for that, there's social reasons for that. And if you can find a way to sort of, and there are ways to sort of systematically understand how communities are structured. And so that's what we'd like to be able to do to sort of build trust by connecting people to the structures that are supporting services on the ground. And then finally, and this is the most important part of the trust fabric, it's also the hardest, it's reaching people where they are. And so it's leveraging the power of networks, both from on a person-to-person level, but also sort of, it's all about the person-to-person level. And finding ways to have those face-to-face conversations. So we'll often see community engagement efforts that are basically about focus groups that are representative of the state population, and those are incredibly important to inform policy. But when you're talking to a group of like 5 focus groups where you talk to 75 people, you're missing 8 million minus, or 9 million minus 75. So I've been lucky to sort of do some work on the ground around the Michigan BioTrust for Health. And what happens when you have these community conversations is 3 things. People are like, wow, that's really cool. And then they're like, oh, that's a little bit creepy. And then they're like, actually, that's really cool, but I'm glad that you asked. And the act of asking buys you a lot of time to do the work that you need to do and sort of get it right. The other thing that we can do is leverage the power of social networks. So Facebook is a magnificent way to get the numbers that you need. So this is an example of a campaign that we ran last spring. So this ad only ran for a week, but it reached a little over 100,000 people. People clicked on it. People engaged in it. People, hundreds and hundreds of thousands of people saw it and were able to sort of begin to sort of have this, maybe not in the front and center of their mind, but it became part of the conversations that they could have at their dinner table. For that week, we spent $225 to promote it. Overall, we spent $15,000 over 12 weeks, and that's not a lot. And there are now sort of 9,000 people that if we want to tap into and sort of let them know that something's going on, they're there. So once you've made this initial investment, you have the force behind it that you need. Okay, so what does the trust fabric look like? This is what it looks like. And you have sort of an empty space that's now full of the people that you want to be able to support the infrastructure. And you can communicate to them your competency, your integrity, your fidelity to serve their interests. And it's all powered by connection. That's all. Thank you very much.
Are there questions? Can we get mics up front?
Looking at the last slide, if it's possible to bring it up, the word that I really like that's missing from the slide is the word process. And it has always struck me intuitively that learning systems is really a great thing, but it always strikes me that the challenge is really connecting information from many sources and incorporating it into a process that systematically incorporates information into action. And so process management and learning systems to me are very connected, and I was just wondering if you could comment on that issue, because I wasn't really hearing it emphasized, and to me it's sort of a major thing.
So great question. Thank you. I'll start. Others will chime in. The word process did appear. If we recall my ring there, the word process is in there, and we're very aware of that. We are doing a lot of thinking about what a complete infrastructure or platform for supporting a learning health system at any level of scale might look like. And one of the exciting aspects of this is that it might work pretty much the same way at any level of scale, and that would be a wonderful thing, because we wouldn't have to build it all over again when we went from one level of scale to another. I have a slide that I don't have with me, but you can kind of imagine it, that takes that learning cycle and attaches at every point around an outer circumference, call them services, that would have to be provided by an infrastructure at each of those points on the learning cycle. And some of those services would be people services, some of them would be policy services, some of them would be technology services, for example, to aggregate data. Around that outer circle, those services are connected by arrows. And they have to flow smoothly, very low friction, from one stage of the learning cycle to another. And in those arrows, in whatever it will take, as we think about how to make this infrastructure work, to enable each service and the people who are executing these learning cycles to flow seamlessly from one stage to another, is exactly the process you're talking about. Have we solved it? No, but it's in the blueprint. And if you have some good ideas for how to do this, we'd be thrilled to hear from you. Thank you for your question. Other?
I just want to say there's an increasingly huge amount of process on that blue side, okay? There seems to be almost no really organized process on the red side. And the concern seems to be everybody's learning stuff, because we have to, because we're under huge pressure to transform, but we haven't got much discipline in how we compare notes and how we formalize what we've learned and how we extrapolate and then put into a database that information so it's computable and able to be served up on demand. And so I would say we're at the earliest possible stages of beginning to say, if we want knowledge and learning to scale, we're going to have to apply some rigor and some discipline to figuring out what learning and actionable knowledge is so we can get the reuse. But I don't think we have great quality improvement initiatives, but they're kind of happening in lots of different places. And the best ones produce evidence-based medicine that goes into journals and gets published, but then takes, 17 years to find its way into practice. So I think we have learning occurring, but we are not systematizing it and making it really a machine. So I'm not sure that process is well defined yet.
Thank you.
Other questions?
Can you help me understand how far to take the library metaphor? I mean, right now I go into a library and I feel overwhelmed by books, and there might be books on very similar subjects, and so can you just sort of help me connect this idea of a library and how we actually help at the end of the day, finding the piece of knowledge that is the best book for me?
Sure, absolutely. I'll try. So you've put your finger on a huge challenge, which is that it's one thing to collect a massive library of computable health knowledge, but it's another thing to make it applicable in the moment. And in fact, the library itself is not enough to do that. So that raises the question, okay, then what else are we going to need to do that? And so a couple of interesting things that we're working on that would work in conjunction with a library of computable health knowledge begin to come into play. And the only reason they didn't appear here today was because of time and constraints and being able to describe parts and pieces. But a big part of this, I'll mention two things. One, a big part of this is not only having computable health knowledge, but then making it available through some mechanism. We're thinking of application programming interface type web services mechanisms, so that all different types of health IT can now interrogate that knowledge and do something with it. That's the distribution and dissemination point, potentially, and it's very important, and it needs to complement the library. And then part of the knowledge that will need to be in the library will be knowledge actually about which knowledge applies under which circumstances. So we have some interesting ideas in that area as well, using a person's own health data, essentially conceptually as keywords to go out into the library and search. So based on that person's characteristics, you could actually bring back potentially relevant knowledge. Some interesting ideas there, a lot of complexity there as well. Not a panacea, but something to be explored. The next piece that I'll mention is a direct connection to electronic health record systems, which I sort of implied in my last comment, but we're looking at fast health interoperability resources. We're looking at building out additional componentry so that we're keeping up a pace with what's going on in the health IT community, and particularly with electronic health record systems, so that there can be a powerful and effective interaction between these systems to the point where we can deliver individualized, tailored messages from a library system like this as the foundation through these other mechanisms that I just mentioned. So this gets us into a clinical decision support context, but perhaps much more individualized and tailored than we've been used to so far. And the literature the way I read it tends to suggest that that's absolutely needed. There's more individualization, and so that's an important aspect as well.
Other questions?
Hi. Got a question.
Does that mean you're not going to let me?
You can applaud after my question. So, when I speak to folks from other states and see their presentations, they frequently list their goal and objective of becoming a learning health state. Do you have any thoughts or opinions as to which states appear to be the furthest along towards becoming a learning health state? Where do you see the progress occurring?
Well, of course, Michigan, but no. I don't get out much, so I let Dr. Friedman answer.
So that's wonderful. I've never heard of anyone getting applauded for a question before they asked it. That's amazing. And your question, of course, deserved the applause. My answer is I don't know. There's no great situational awareness around development of learning health systems at state scale. There's more awareness at organizational and network scale. I can talk about Minnesota, which has, to some significant extent, adopted this as a goal. And like Michigan, I think Minnesota is trying to leverage a lot, as Tim was describing for Michigan, several elements of infrastructure they are building and trying to figure out how these elements of information infrastructure can come together to move Minnesota toward becoming a learning health state. If you have heard other states articulate this as a goal, You know things I don't know, which is great, and I'd love to hear what you've heard.
Other questions? Well, please help me thank the panel, even though I'm on it, and